Good morning, everyone. It's the 10-year anniversary for the School of Public Health, in case you didn't know that. So happy anniversary to us. My name is Sarah Woodrum, and I serve as the Senior Associate Dean for Administration and Finance in the school. It's very hard to believe that the public health school is 10 years old. I'm truly amazed as I look back at what we have accomplished. Since our inception, we've more than doubled our academic offerings, all while maintaining a steadfast focus on fulfilling our mission through research, learning, and outreach. It is an honor to be with you here today, and I thank you for joining us, to both those of you who are in the auditorium, and we also have people online. Many of you remember that in early 2020, a lot was happening around us, and it was affecting what we could do and how we could do it in our everyday lives. However, while most of us were comfortably studying and working in our homes, there were millions of healthcare workers that couldn't do that. They had to report to work every day while often putting in extra hours during a very scary time and an unprecedented one in our history. They put their lives on the line every day to save others and protect each and every one of us. While the efforts of these staff were heroic, so was the work of the leaders that worked tirelessly to get us through that tough time. Lucky for us, we had great leadership and amazing vision that put West Virginia on the national map for our readiness when it came to COVID testing and vaccines. Today, we're joined by several of these key healthcare leaders that were and still are an important and strategic part of the leadership group that saved so many West Virginia lives. This is why we are here today to hear our experts talk about leadership in crisis, lessons learned from a pandemic. Next, we will hear from each leader, who will share their perspectives on how they navigated through the pandemic as individual leaders and as part of a bigger team. We'll also examine the lessons that were gained from those experiences and how they can be applied as we think about the future of public health and healthcare in general. Also, I am very thrilled that joining us today as our moderator is April Call. April's the Director of Communications for University Relations and Enrollment Management at West Virginia University. April is a West Virginia native, a two-time graduate of WVU, and also in her spare time serves as adjunct faculty in the Reed College of Media. April oversees the day-to-day operations of her unit, which is charged with telling West Virginia University's story. And I personally can't think of a better story to tell than the one you are about to hear. I'm going to turn things over now to April. April, it's an honor and a pleasure to have you here with us today. Thank you for joining us.
Sarah, thank you very much. And I apologize, but I will be taking my readers off and on quite a bit throughout our discussion today. I'm thrilled to be here, and I'm really excited for this conversation today. And I'd like to echo Sarah's comments in greeting all of you here in the room with us, as well as the many more who are joining us virtually from wherever they are, to talk about the importance of public health and the contributions of the School of Public Health here at West Virginia University. We have a fantastic panel joining us today. And I have to say, I was really struck that the anniversary of the School of Public Health coincides with West Virginia University's homecoming, because homecoming is all about community and being together and the members of our larger Mountaineer family. And that really speaks directly to the mission of the School of Public Health and the work that happens here to help our communities be healthier and to live better lives. And so I think that that really can serve as the basis of our conversation today. Joining us as members of our panel, Dr. Clay Marsh, who serves as West Virginia University's Chief Health Officer and the WVU Health Sciences Chancellor and Executive Dean. Dr. Marsh focuses on finding statewide solutions for health and well-being, and he shapes the direction of the university's 5 health professions: schools of dentistry, medicine, nursing, pharmacy, and public health, and its statewide allied health programs and clinical operations. He also co-leads WVU Medicine, West Virginia's largest healthcare enterprise and the state's largest employer, and serves as the state's lead representative and spokesperson nationally and internationally in areas of health, health education, and academic medicine. In response to the challenges of the pandemic, Dr. Marsh was appointed COVID-19 czar by Governor Jim Justice in March 2020, a role he continues to this day. Dr. Jeff Coben is Associate Vice President for Health Affairs and Dean of the School of Public Health here at WVU. He's achieved international recognition for his accomplishments in the field of injury prevention and control. His research and health improvement projects utilize clinical, epidemiological, thank you very much, and health services research methods. Since joining West Virginia University in 2004, he has served as the director of the Center for Rural Emergency Medicine, the director of the Injury Control Research Center, vice chair for Research and Emergency Medicine, associate dean for operations in the School of Medicine, and associate vice president for clinical innovations, planning, and operations for the Health Sciences Center. And he has directed a number of statewide initiatives. And perhaps most prescient to our conversation today, when Clay was appointed as the state's COVID-19 czar, Jeff was tapped to assume the responsibilities and duties of managing the oversight of the Health Sciences Center and played a key leadership role in guiding the university's response to the pandemic, for which I know I can say we are all very grateful. Next, I'd like to introduce Bill Crouch. He was appointed Cabinet Secretary of the West Virginia Department of Health and Human Resources in January 2017 by Governor Justice. Early in his career, Bill spent several years working as a nuclear medicine technologist and as a laboratory technician in acute care hospitals. During his time, he also earned a Master of Public Health degree, which he has put to use here in West Virginia for 10 years. First at the West Virginia State Health Department Office of Community Health Services, and then later as the first executive director of what is now the West Virginia Healthcare Authority, where he stayed through 1986. In 1987, Bill started his consulting firm, and for the next 30 years, his company provided healthcare management and consulting services to a number of healthcare organizations and physicians. Now, Bill retired in 2016 in July of that year, but he will be the first to tell you he failed miserably when it comes to retirement. And so now he is the Cabinet Secretary of DHHR, dedicated to protecting the health and well-being of all West Virginians and improving the health of communities across the state. I'd like to introduce Margaret Kitt. Dr. Kitt is an occupational medicine physician who served 34 years in federal service. She spent 30 years active duty, 14 years as an Air Force flight surgeon, and 16 years as a commissioned Corps officer in the United States Public Health Service, retiring as a Rear Admiral. She worked at the National Institute for Occupational Safety and Health, NIOSH, part of the Centers for Disease Control and Prevention from 2002 to October 1st of this year. She served as the NIOSH Deputy Director from 2009 to 2022, completing her last 4 years as a NIOSH Distinguished Consultant. Dr. Kitt played a leadership role in numerous disaster and humanitarian crises, including 9/11, the Deepwater Horizon oil spill, as well as the COVID-19 pandemic. Welcome, Dr. Kitt. And last but certainly not least, I want to welcome Lee Smith. Dr. Smith is a physician director and county health officer of the Monongalia County Health Department in Morgantown, West Virginia, which, if you didn't know, is the state's largest health department. He's responsible for providing day-to-day management and oversight of the department and all of its programs. He joined the health department in 2014 as its county health officer and executive director, and has maintained that role throughout the majority of the COVID-19 pandemic through December 2021, at which point he announced he was going to be shifting back to what I assume is his first love: research, clinical matters, and education, as part of the health department's medical director role. He works as an immigration civil surgeon running Health Department's International's travel clinic, and he oversees the STD clinic as well as its patients. He developed a county-wide quick response team for opioid overdoses and has been at the forefront of our county's COVID-19 pandemic response. So please give all of our panelists a warm welcome. There is a wealth of knowledge and experience on our stage. We're going to tap into that. So I'm going to go through a few housekeeping notes just to let you kind of know how we're going to run our panel conversation this afternoon, so you know what to expect. We're going to begin with a conversation here on the stage, and I'm going to get things rolling with some questions for our panelists after we give each of them an opportunity for opening remarks. But then we really want this to be a robust conversation, and we want to hear from our virtual participants as well as those of you who are here in the room with us. So if you are watching virtually today, there is an opportunity for you to drop a question into the Q&A function of our event today online. So be sure to do that. We have someone monitoring, and we'll be sure to get to those as part of our Q&A section. If you're in the room, what we'll ask you to do when we get to that section of our program is just raise your hand, and we have a couple of people with microphones who will get to you so you can ask your question in real time. But first, I want to get our conversation started, and I want to begin with Dr. Coben. I'd really love it if you could share some of your initial thoughts about the topic of today's panel, which is leading in a crisis. For example, what insights have you gained in the past couple of years as we've all navigated the COVID-19 pandemic, and you've led that navigation here at the university?
Well, thank you, April. First of all, I'd like to welcome everyone and thank you all for coming. It's great to have everyone here today. Secondly, while we're here to talk about lessons learned, I would be remiss if I didn't mention that the pandemic isn't over, and we're still working on it, and we'll continue to be working on it. So with that, I would say that, you know, for me personally, what I found to be the most interesting part of working through this process has been learning to participate as a member of a team, and hearing the perspectives of others. While it was important to play the role and be the voice of public health, that I also needed to understand that there were many different perspectives, and that if I was to state my case and say that this is what has to be done from a public health perspective, and then leave if others disagreed with me, that would have really not been helpful to the team and to the university and to our overall response. So it's a matter really of not being overly dogmatic while still allowing my voice to be heard, but first sort of seeking to understand and then seeking to be understood. I felt like, as President Gee is always saying, we are the people's university, the land grant institution. What I learned was that there are many, many different perspectives and many different constituents of this university. So while my role was to be the voice of public health and to try to bring best public health practices to that conversation, I also needed to learn what those other constituents were voicing, what their concerns were, and how we could best navigate together collectively. So I would say that, you know, really that's what's resonated the most with me, was being at the table and staying at the table, even if I disagreed with certain decisions, and disagreeing without being disagreeable was a key part of that experience for me.
Dr. Marsh, going from a more university level perspective, take us to a state level as the COVID-19s are in your role during the pandemic, and the lessons and the observations that you've had.
Well, thanks, April, and thank you guys. Thank you all for being here, and congratulations to the School of Public Health and to Jeff and the leadership team, really amazing, and to the faculty and the students and the staff who work in our school. We're really, really proud of the work that's being done. You know, there's many lessons, April, that I think that we have learned at the state level, and I'm right here on the right side with a failed retiree who will also give you his thoughts. But let me just list a few without going into grand detail for the sake of time. So number one is we have learned to be self-sufficient. We have liberated the university in a way where the university came to the call and the need of the state to create PPE to protect people, to create testing, to be able to define COVID-19, whether it's PCR testing or next generation sequencing testing or quantitative antibody testing or wastewater surveillance with next generation sequencing testing. So we made moves early to become self-sufficient. The second thing is that, and Jeff mentioned this too, that we created what I believe is a really strong team where we had a lot of complementary talents. And we worked very closely with Lee Smith and the county health departments. We worked very closely with the National Guard, with NIOSH. We helped define some of the material to create gowns and masks. And what we figured out early was that there was no playbook for COVID-19. So part of the team construct then really mirrored what Stan McChrystal has written about in Team of Teams, where we got rid of a lot of the parallel structures and the keeping information to the organization that knew it and sharing that broadly across the organizations. And that's really the reason why we were able to be first in the country to immunize our nursing home and assisted living population and also our elders, because we knew that the federal pharmacy program or vaccines that came through CVS and Walgreens wouldn't work for us. We didn't have enough of those in small parts of West Virginia. And through the pharmacy board and through the long-term care association leadership, we figured out that the relationship between family and privately owned pharmacies was the pathway there. And so we went to Operation Warp Speed and told them that we weren't trying to be rebellious. We just didn't think that worked for West Virginia. And they said, well, follow your own data, but keep the option open, which we did. And eventually that was beneficial as well. But we were able to not pre-script an approach, but we really responded to the way the virus was acting and the information we were finding. The third thing is we used all assets we could to predict and give us some foreshadowing about what was going to happen. And it turned out that as it is now, we look across the, to the opposite side of the world and we see that Australia's had an early flu season. Well, Israel turned out to be an incredible asset for us around the impact of boosters and how we might want to handle that, the UK. And then in the US, because we're a rural state, we saw more populated states, urban centers, New York, LA, when they started having problems, we knew in several weeks those problems would come to our front door. So it gave us an opportunity to prepare and get some foreshadowing in. And then the final thing I'll say, which I think is a super important and I think previously unappreciated, but no longer unappreciated capability that we developed here, was the issue around crisis communication. Because I think if we've seen something fail in our country, the one thing, it's been the amount of distrust and the lack of confidence that we've seen people have in absolutely life-saving interventions. And by that, I mean vaccines and antiviral medication, and then, being smart about mitigation measures. And we know today that only about 8% of vaccine eligible people in our country have gotten the updated Omicron bivalent booster vaccine. About 20% of people over 65, which is bearing the greatest burden as far as hospitalization and mortality. And we know that COVID hospitalizations now, for the first time since July, are starting to rise again. And so we have a life-saving therapy. We have a treatment, if you use that vernacular for vaccines, that will predict everybody, that will prevent everybody from dying and prevent most people from getting sick enough to go to the hospital and protect you about 50% from developing long COVID. And only 8% of our vaccine eligible population has taken it. That to me is a tale of epic proportions and gives us the insight onto a path that we have to really focus on for the future, which is to rebuild trust and confidence, not only in science and medicine, but really in the public health efforts that we want to take and extend beyond COVID to try to help both West Virginia, our country, and our world be healthier and happier with much higher levels of well-being. Thank you.
Dr. Marsh, thank you. And as a matter of fact, we just published a new research article earlier this week that deals with some of the potential reasons why people might have some hesitancy or distrust or strong feelings one way or another about vaccines and other elements. So I would encourage people to check that out. You can find it at wvutoday.wvu.edu. Meanwhile, Secretary Crouch, I'm interested to hear your perspective, as you're hearing, Dr. Marsh and Dr. Coben talk about, the university and then, Clay's perspective. From DHHR's perspective, what lessons can be drawn?
Thank you, and thank you for being here, and thank you, Jeff, and congratulations, Jeff and Clay and everyone on 10 years of a terrific program that's doing a lot for West Virginia and surrounding states and the country. Some of the things I see being done at West Virginia are just kind of mind blowing in terms of the Rockefeller Institute and some of the efforts. So congratulations on everybody for those efforts and the public health efforts. But one of the first things I learned, and this has been a journey. I've told folks who really feel like kind of lost 2.5 years of my life. It was so focused on COVID and so focused on what we were doing to try to keep folks healthy. And one of the first things I learned was to follow Clay Marsh, because he always says everything I want to say. So he's, but it's the team, it's Clay and the National Guard and Jim Hoyer. And I don't want to leave out Jeff Coben. A lot of people really don't understand or realize how much I relied on Jeff throughout this pandemic. I would contact him when I was kind of stumped on issues. And everyone up here is a physician but me, and that doesn't mean I won't give you a medical opinion, but it does mean I'll be the last one to give you a medical opinion. So, but it's that collaboration and that team that we put together and the governor put together to get us through this. We couldn't have done this alone. DHHR could not have done this. I think some states relied more on their state programs to do this. West Virginia is rural, very difficult to get to 55 counties with test kits in one day. If you've got 2 people who do that transportation. So the National Guard stepped in, did an absolutely phenomenal job. General Hoyer helped guide us through those logistical parts of this. Can you hear me all right?
It's on. You're being way too soft-spoken. Shout from the rooftops.
I'll get a little closer. Sorry. Yeah, Jim Hoyer with the National Guard did an absolutely terrific job. I tell everybody he compared pretty much everything to tribal clans in Afghanistan. So, but that did seem to work in terms of looking at strategy and logistics and how we do things. And if we needed something done statewide, they were there and they did that. And that led to issues. When you have a couple of hundred people out there providing test services through testing lanes and trying to get information, the information is not always right. It's not always collected properly. So then we double back on the data and try to fix the data. And that was just one part of that we had to deal with. Just an amazing number of moving parts to try to keep things going. And I tell everyone, I'm not a medical person, I'm not an attorney. I'll give you a legal opinion too, but I'm not an attorney. But I tried to keep the train on the tracks. I tried to keep things moving, and where there were issues, problems, tried to fix those problems. So I so much appreciate the team we put together. Jeff and Clay have become close friends, and I value that and will always value that. But this type of crisis is not for everyone. We also had folks who could not do that, who could not deal with that day-to-day pressure that went into the evening. I can't tell you how many times for months and months, we would talk until 10 at night. We would be on Zoom calls at 7, 8 night with different counties or testing vendors, a variety of folks who had to connect with what we were doing in order for us to have the tools we needed to try to take care of folks. And it was constant. It was 7 days a week. It was Saturday. It was Sunday. Governor likes late night calls. I'll tell you that. We would be on the phone with the governor at 9, 10 o'clock at night, trying to make a decision. And again, a lot of folks can't do that quickly. They need time to process. They feel the need to solicit advice from others. And I've always said Clay and Jim and I could get together and make a decision in 5 minutes. And of course, that's what the governor liked. And we kind of related that to war a little bit from the standpoint of some people can do that, operate in that environment, and some can't. And I say that because I have direct knowledge of people who couldn't do that in DHHR. We had folks who left. We had folks who really had problems dealing with that, and not only had to leave their job, but had to get medical care because of the crisis was that serious to them, and wanting to do a good job, but not being able to deal with that type of environment, making decisions under pressure and quickly. So we had one suicide. We don't talk about that a lot. We had one person commit suicide. We had others who were under a lot of pressure. I've told the story about an email I got to my generic DHHR secretary.gov. Y'all can send an email there. I don't get them, but the box is reviewed daily by my executive assistant. So if there's something important, she does push that to me. And I got this email that someone had walked to the top of the parking garage after leaving court and dealing with a child welfare case, and was thinking about jumping off. And it was a terrible 6 hours trying to track that person down and make sure that person was safe. But it was the pressure of that job, which all of that ends up being part of more pressure on everyone when you have a pandemic you're dealing with. So, well, we have a great team. Again, our partners out there, Lee Smith, all of our local partners have just been terrific. It's we've hit a few bumps in the road here and there. Lee may tell you about some bumps, but we got through that, and we got what needed to be done. So I thank all of them out there. But again, thank you all for your interest in public health. I love to come up here and see folks and see students who are interested in getting into this field. It is important. It is crucial that we get more folks into public health and into government service. I try to talk folks about getting into government service. We need more young people, bright young people who will end up being superstars in government. So I thank you all. Thank you.
Thank you. And, you brought up a couple of really important points. And one of those, I think, was how the response to the pandemic and the ability to lead through it was not a one size fits all approach in many ways. And so, Dr. Smith, I wanted to lean into you, as the director of a county health department. The challenges that you were facing here in Monongalia County might be very different from those of the county health director in Ward County, for example. So what was your experience like, and what lessons have you taken away as someone working at a county level?
Well, that's a great question, but
I'm going to ask you to cozy up to that microphone. Get nice and personal with it.
I'm usually not accused of being quiet. First, I wanted to congratulate School of Public Health on their 10th anniversary. I think it means a lot to the state and to this institution. And we've been very excited and proud to be part of that. For the last 3 years, we've been an academic health department, and we have shared staff and affiliate faculty, et cetera. And so we're in lockstep with this institution and particularly with this school. So congratulations and thank you for having me. I think if I were to sum up the lessons that a local health department might talk about, in a word, I would say it's relationships. And I would suggest that Montague County got out of the gate pretty fast because we didn't have to form a lot of relationships. We could pick up the phone, and I have all of this panel on speed dial. And yeah, I don't know whether they screen my calls or not, but they but we've all spoken and tried to address problems. And I really appreciate Jeff's comments about his job of mediating input to develop policy. And he and I have agreed to disagree on things, but you don't have to be disagreeable. And as long as your voice is getting heard, in my world, that's probably as good as it ever gets. And, you know, this is the real world, and you have to, you know, play the cards you're dealt and move on. And I think that our job in the Department of Health at the county level is to take the policy and what the thought leaders are coming up with and interpret it into a work. And the School of Public Health has as its three-legged stool research, learning, and outreach. And we have interaction with all three of those formats. And our charge, if you will, from the West Virginia legislature, we are required to prevent disease, protect the public, and promote the public health. And we were not immune to people telling us that I didn't sign on for this. This is a little bit much. And we quickly ended up having to go to a 7-day work week, and we had split that into 2 groups. And it was much. It was a bit much for a lot of people. And people did work long and hard, but it was a labor of love because we're serving the people of West Virginia and our county, and not just the residents, but the visitors as well. And so if you align with a job in public service, this is what you're going to do. And this is what I think is a higher calling. And so I would encourage you that are considering this pathway to make sure that this is what you want to do, because there's plenty of work to go around. I don't envy Cabinet Secretary Crouch sitting here with me because he has oversight of the entire state. Now, there are 55 counties, but 49 health departments. And as I will tell you, if you've seen one health department, you've seen one health department. And if you're been around West Virginia a short period of time, you know that we can be very, you know, clannish and to you know, Dr. March's comment, we work in silos frequently. Now, people will tell you that that's a cylinder of excellence, but that's not true. That's a silo. And so trying to have an equitable type of public health delivery is challenging. And we're fortunate here in Montague County. We have a growing population. We have a lot of infrastructure. We have thought leaders that are active in the state, and we have resources. And one of the things that I think helped us get out early is that our staff believed wholeheartedly that we were going to do what we could to protect the public and prevent disease and promote the public health. And Dr. Marsh had beat the drum saying that West Virginia is an elderly population and a vulnerable population. And we want to ensure that we prevent COVID from getting a big foothold here because it could be devastating to our population. And so we quickly and aggressively teamed up with the National Guard. And I think back now with a smile when we were wearing PAPRs and PPE and Tyvek suits and going into nursing homes. Well, we were there on day one. And we were very aggressive with our assessments of people. And so trying to identify who is sick, who is not sick, who needs to go in isolation, who needs to be in quarantine, working with the nursing homes, developing these quarters within those homes that then we could translate over to how do we do it with dormitories? How do we work with the Coalition to End Homelessness so that we have hotel rooms for people that are homeless but yet positive for COVID? And so we were able to meet the call and worked very hard. And we had lots of help with NIOSH and CDC, National Guard, many others, the School of Nursing, School of Public Health, volunteers. And we were able to do disease investigation and, trying to get the list together and for our contact tracing. And what we realized is that we were too small. We were punching above our weight. And what we really needed was, if you're going to go out and do a community testing event and try and do 1,000 people, you needed at least 40 people. And so we quickly translated our needs into a work plan. And I need X number of people to register. I need X number of people collected swabs. I need X number of people that are going to run these specimens back and forth. And we worked on that and we polished that. And by December of 2020, when the vaccines became available, we stepped up our game and we were at the National Guard Armory. And if we thought we did 1,000 vaccines in a day, we thought we were world beaters. And it became pretty clear early on that we would not be able to maintain that level of effort. We're a small group. We don't have reserves. And so an opportunity came up with David Goldberg and Albert Wright, Dr. Marsh, Dr. Coben, the leadership out at the Federally Qualified Healthcare Center in Blacksville, Rebecca Thomas. And they said that we could work in unison at the old Sears building. And so we jumped at that opportunity because it was more than we could do. We knew that there were hundreds, if not thousands, of vaccines that needed to go out, but yet we were unable to do it on a day-to-day basis. And so we were glad to work with that partnership. So there's that word again. We had that relationship. We were able to capitalize on that. And we got the working with that group, and I think served this county and soon to the region, if you will, because a lot of people decided they could come here and get things done a lot easier. But I kind of digress. We have worked hard, but we've done so with a group. And now that we've sort of gone back from the Sears because there aren't those volumes, we continue to do outreach and we try to get vaccinations out, but it is difficult because of the reluctance that people have. And there are people who are early adopters, and all you have to do is publish when the vaccine is going to be given, and they're going to be there, and they'll bring their kids. And then there are a big group in the middle that, for numerous reasons, have been a little reluctant. They've been hesitant. And some of them are well-founded, and some of them is just that there's some confusion. And then there's a last group that's a minority group that have made up their mind that they're not going to get vaccinated, that it's the work of the devil. And, I'm just not going to be able to convince those individuals. I don't have that much time left in my life to convince them. And so we concentrate on the early adopters, and we concentrate on the people that have yet to make that commitment. And we've done several projects and videos to try and get people to understand. And we were very fortunate to work And we even had Governor Jim Justice help us with a video because he is a COVID survivor and talked about his experience of having it. And this is something that you can avoid with vaccination. So anyway, I'm a little off target here, but I want to say that a lot of these relationships continued to be built with time. Some of this we were building as we were flying it. But having a basic introduction to all these women and men that are hard chargers was the key to our relationships. And so I'm eternally grateful that the things that we did had a lot of impact. So we're not out of the woods yet, but appreciate that. Thank you.
Dr. Kitt, you just heard a lot about relationships, collaboration, coordination from Dr. Smith. And, so I want to kind of back out again to a larger level. And, much of your work has centered on those sorts of collaborations between national, state, local, regional, and even international at times efforts. So what has been the pandemic experience for you, given your background and experiences at those various levels and seeing how they work together or don't work together?
Well, thanks, April. I have to say first that I haven't filed at retirement yet. It's only been 4 weeks today, but so far so good. But also happy anniversary to Dean Coben, the faculty and the students, the School of Public Health. So when I was thinking about what I wanted to talk about today, because, obviously I did work at the federal level, I went back to a number of sort of guiding principles that I wanted to just touch on, many of which have already been mentioned today, including those partnerships and relationships. I think leadership in crisis goes back to planning ahead of time. And that's not just having plans, but knowing what resources you have, whether that be financial resources or probably more importantly, human resources. And, what gaps you have, and how you're going to fill those gaps, and making sure that decision leaders understand those types of things sort of in advance. They may not be able to do anything about filling those gaps for you, but at least you can make them aware. And then I think, as Lee was talking about relationships and partnerships, having those relationships ahead of time, you need them for your everyday work, but certainly during a crisis, you really need them. And being able to rely on them to not only fill some of the gaps that you may have, but also to augment the capabilities overall, to build strength as a community is very helpful. My background is in worker safety and health, and some of the things that Bill touched on are very important to me. It's important to thank your people as time goes on, and this was a really sustained pandemic response, and acknowledge the heavy lift that they're doing. But it's also really important to be vigilant and to watch what people are doing, the people that work for you, what they're doing, what they're saying, and what they're not saying, and to make sure that you're paying attention to them, because if you start to see them falter, there's probably a reason, and to try and look into that reason and try to take care of them. I can tell you that there were many instances where my and my senior staff identified some issues that were going on in some of our workforce, and we tried to intervene as early as possible in order to find solutions for them, because it isn't for everybody, and or people just get tired and they need a break. So the third thing that I just wanted to mention is that it's really important that you're willing to work outside your comfort zone, because you're really going to be pressed to do that. And that really makes you have to rely on who your go-to people are and know who they are, and to also capitalize on their expertise. And then it often goes back to those relationships as well outside of your own organization. And the last thing I wanted to mention is something that Clay talked about. It's really important to have a good communication plan and a good communication team, because you can't do it all yourself. And most often some of the information you're trying to pass on isn't complete. And people don't want to hear that you don't have all the answers just yet. So having that communication team and plan to work on that in advance and on the fly is really important, because those messages have to get across, and you have to be as transparent as possible when you're transmitting those answers. So that's sort of the key messages that I sort of wanted to relay today.
Thank you very much. As a person whose work every day is focused on communications, I very much appreciate those comments, and certainly communications has been a key component of the pandemic response as it relates to public health. I want to open things up for questions from our audience, both here in the auditorium as well as online. So again, if you have a question and you're here in the room with us, just make sure you raise your hand, and we have a couple of people who have microphones, and we'll get a microphone your direction. So just raise your hand up really high and let us know if you have a question. And I'm checking in for the first time to see if we have any questions online. Not yet. So in the meantime, while people are thinking about whether they have a question, I have more questions. Shocking. And I'm going to start with you, Dr. Coben. Talk a little bit about what things looked like for you as your responsibilities shifted from leading the School of Public Health to overseeing all of health sciences here at the university, as well as fulfilling that leadership role that the university was playing as it related to the pandemic response overall. What was that shift like for you?
Interesting. No, I mean, Margaret just mentioned human resources, and Clay's previously spoken about teams of teams. And I think that really is what resonated the most with me and what I relied upon. I felt very fortunate that we've worked for the last several years to build strong teams, both at the Health Sciences Center under Clay's leadership, with our associate vice presidents and the deans of our other schools at the Health Sciences Center. And I felt the same way in my responsibilities leading the School of Public Health and the Office of Health Affairs, in that we developed strong leadership teams within all of those units. So it made it quite a bit easier for me to be able to pivot and to rely upon those individuals to really do what I knew they could do, and in many ways better than when I had been involved. And by stepping back, they flourished, and we actually saw quite a bit of growth in those areas as I was attending to some of these other issues. So I think that really what resonated the most with me was the team of teams concept, and understanding really the importance of spending the time to develop those teams so that they're in place, so that when you have changes, in leadership, when you have crisis situations, you know you've got a strong group of individuals who you can rely upon. At the School of Public Health in particular, our associate deans, our department chairs, but even our individual faculty members who led efforts throughout the pandemic, both in the community and in developing training programs related to that. And then finally, I would say, as I was asked to join the university leadership team, I relied on some of the expertise that I knew existed here at the university, in our School of Medicine, in our School of Public Health, in other places, and brought them together as a new team to help on a more sort of day-to-day basis, thinking about public health response and our health response. And Lee Smith was a part of that team as well, with the community connection. So to me, that really was what resonated and helped us get through that process.
Thank you. And I know we have a question here in the back. So Nikki, I'll let you get the microphone. And if you could just say your name and your relationship here at WVU, if it's here with the university, and if there's a particular person on the panel that you're directing your question to, that would be helpful.
Yes, I'm from the faculty. I'm Gordon Smith, professor in epidemiology. I first wanted to say how impressed I was with the way West Virginia dealt with the epidemic and the whole problem. But what I'm particularly interested in is to get some comments from the panel as to just where we went wrong as public health workers in the whole miscommunication issue. We have West Virginia with one of the highest immunization rates in the country prior to this whole fiasco. And now we have all this problems with large groups being in mistrust of what we're doing. And the epidemic is not over. We still very much have a problem with COVID, and we should be wearing more masks. Thank you.
So I'm going to ask Secretary Crouch to begin the response on that. And then anyone else who wants to jump in with thoughts, please feel free to do so.
Somehow I thought that was coming to me. We did start strong. We were the first in the country to immunize every nursing home resident and staff who wanted immunized in the country. Clay alluded to the fact that we were the only state, I think he said the only state, but we were the only state who didn't follow the federal approach of using the two largest pharmacies in the country. We had very few of those pharmacies in rural West Virginia. So we made a tough decision and a bold decision to say, we're going to do this our way. We're going to get folks immunized in West Virginia faster by doing it our way. And we did that. And we were number one. Where we hit the kind of the wall, the brick wall, is what Lee Smith referred to earlier. Those categories of folks who, the group in the middle, we work hard to try to convince those folks that they need to get immunized. They need to get boosted. Our boosting numbers across the country, but in West Virginia, are dismal. So this pandemic is not over, but folks think it's over. And I always tell a story about Clay sending articles. He's slowed down slightly. He used to start getting them at 5:30 or 6 in the morning, 10 or 12 articles a day, trying to read those while I'm dealing with, and I'm not the only one getting them. He's trying to educate me, but I'm a little harder to educate than some folks. But it's wonderful to have that knowledge of what's going on elsewhere. And we have, and let me just say, I don't think there's anyone in the country that has a better understanding of where this virus started, where it's been, where it's going right now, and where West Virginia stands with regard to that. Because we watch Israel, who was in the lead on this pandemic in terms of vaccinating folks early on, and then it moves. But we always knew where things were, and we always knew we were about 3 weeks behind the rest of the country in terms of what was happening across the country. So Clay helped us have a vision of where we were going. So kind of a roadmap there. But as we watched that data, we saw some countries, some states succeed more than others. Some began to have better vaccination rates. Some began to have better boosting rates, although again, those are not good anywhere. But West Virginia started lagging behind. And we have a population who's very strong-willed. They're very strong-willed. There are folks who will not take this vaccine. And I've said this a couple of times, but I try to be careful because just like the governor, I respect their decision to not take the vaccine. That's a personal decision that folks have to make. I get a little confused when they won't take the vaccine that's been given to 12.7 billion people worldwide, but they will take horse medicine. They'll take something that they think somebody said will work. That I have a problem in terms of public health understanding, but that's where we are. We have pushed and pushed. I want to give the governor credit. How in the world do you navigate a population where you have those categories that Lee talked about? We had people almost fighting to get to the front of the line when this vaccine first came out because they were scared. They were scared, and we didn't know the extent of this virus, and it's killed so many people. I mean, 7,500 in West Virginia. The early predictions were we were going to have 5,000 deaths. I remember the meeting in the governor's office, and we were all scared. the governor was, we can't have that. We have to do something. And we did do a lot. But back to the question, I don't know that we'll ever get through to those people. As Lee said, he doesn't have enough time in his lifetime to convince them. I don't think anyone's going to convince them. So that's where we hit the wall. That's where we stopped. We had a great program to deal with our elderly population, and we did it. But when it came to adults who needed to make that decision on their own, a lot of them chose not to, and they chose not to for their children. So that's been an issue. So it's difficult. Great question. Again, we started out strong and we kind of hit a wall, and we're still doing what we can to convince folks. But that's part of the public health issue that we need others to get into. We need more people in public health who understands the need for things like vaccines and protection prevention programs for the public.
Secretary Crush, thank you very much. And I know we have Dina Teles, we'll get to you in 1 second. I wanted to add something before. I know Jeff and Clay, I think you had some things to add. But to your point, Gordon, we are looking at how do we address it the next time? How do we improve on the communications response, the marketing efforts, all of those ways that we interact with people and share information? The Eberly College of Arts and Sciences, the Reed College, the Chambers College here at the university, along with Health Sciences, our College of Applied Human Sciences, are all looking at communication models. They're researching. We've had, I just did a quick search. We've had 3 recent pieces that we've published with ongoing research looking at how we can improve and do better, because we know that there is another pandemic coming, and we want to be better prepared to meet those people who are hesitant or are steadfast in their resolve against some of these measures, to better address their concerns as we move forward. So Clay and Jeff, I'll let you follow up because I know you both had comments.
Go ahead first. Okay.
Yeah, please.
I just want to comment and reiterate something that I mentioned to our students on a call on Wednesday. And that I think this does address your question, Gordon. We need to understand that public health interventions oftentimes take much longer than we'd like them to take. And that we need to be in this for the long haul. For some of us, I think it's, we view it as simplistic and straightforward. But I suspect that even John Snow, who hopefully all of our public students know who I'm talking about, when John Snow shut off the pump to reduce cholera, I suspect he was criticized pretty much as well for turning that water off. And if you think about some of the really difficult issues that public health has dealt with over the years, think about balancing the good of the many and the freedoms of the individuals. Think about the progress that we've made, for example, with seatbelts and seatbelt legislation, which took 50 years for people to really embrace and now fully utilize. When you think about smoking cessation and legislation around smoking in public spaces, which took close to 50 years to get implemented, we have to be persistent. We have to maintain a strong voice. We have to advocate for these changes, but we can't lose faith that at the end, we will persevere. And I believe that it may take a generation to get where we need to be, but it will occur. And we just have to keep pushing. We have to keep advocating. We have to keep that moving forward as public health professionals.
Thank you, Jeff. I think that's really important. Gordon, your comment is sage, as I would expect from you, but I think that it's really also important to recognize that we are in a very interesting moment in time, and the COVID pandemic is certainly part of it. But if we look at lifespan in our country, we see that versus other Western countries, we've lost about 5 years of lifespan. We look at our own sort of pre-COVID, we've lost 2.7 years of lifespan and different populations and Native American Indians and Alaskans, I think, have lost more like 4 to 6, and African Americans more like 3 to 5. So we know, and this was a trajectory that started before COVID, the so-called deaths of despair and hopelessness, which really is about people who have lost their perception of their own standing in their communities, so-called social capital, and also people that don't have jobs, which are really important for our community and for our purpose. So I think that not only do we need to look at, as we've talked about, as Jeff talked about, Bill, Margaret, Lee, April, about our need to reassess our communication means, but I also think we have to relook at how we're doing things, because West Virginia is the second lowest life expectancy in the country. And if we look at our worst county in West Virginia, which is McDowell County, and compare it to the best county in the United States, Summit County, Colorado, which is where Breckenridge is, we have a 17-year life expectancy difference. 17-year life expectancy difference. And if we look at people that score high on the Everest Childhood Experience Survey, a Kaiser family assessment tool that was given to 17,000 people that were insured by Kaiser, then we know if you have 6 or more ACEs positive, your lifespan is likely to be reduced by about 20 years. So how we see each other, how we treat each other. I think Teddy Roosevelt said, people won't care how much you know until they know how much you care. I think there's a lot of learning to go on here. And we do have a special group here in the Reed Media College, the Public Interest Communication Research Laboratory that's led by Dr. Julia Frostino, who does evidence-based communications, done a spectacular job. And I think as we look at the challenges of COVID, and I'll be very short here till I finish, there's really the kind of communication that we sometimes put our fingers on or point at and say, these are bad actors that are trying to disinform or misinform. But actually, I personally think Margaret really hit the nail on the head, because I think the biggest problem with COVID is that we were communicating real-time information in rapid cycles that were basically interpreted perhaps differently by different people. And so, for instance, when President Joe Biden said the pandemic is over, well, it's not. And while I know that President Biden was trying to make a positive statement because we've gotten to a better place as far as vaccinations and immunity, but I do think that as we learn to communicate, we need to do it transparently, but we also need to acknowledge that this is unfolding in real-time manner. This is a complex system that we're dealing with. The virus has mutated amazingly, and now we see that BQ1 and BQ1.1, which are derivatives of BA5, now make up 27% of the sequence cases of COVID in the US. And in another few weeks, it'll be the dominant variant. And BA5 was the most infectious variant we'd seen to date. So this is over when it's over. We have the tools, we have the capacity to save lives, to reduce hospitalizations, but we also need to make sure, and we've talked about this community with the response, we need to enrich our own communities. You know, when we talk about diversity, equity, and inclusion, to me, I love the fact that in the middle of the word community is unity. And we know that the root word of heal and health and holy and holistic are the same, and they mean whole together. So we're like this, and we need to become like this. And I think the communication is part of it, but part of it is us caring about each other in a way where everybody feels valued and where we can help people be seen and feel like that their social capital, their standing, their purpose is on a more equivalent level. My own 2 cents.
Thank you very much. Dina T. Lace.
Well, thank you for all that you have done to your leadership to help us stay alive and safe. the context for my question is, we do realize that to think about public health involves not only deciding who owns our health, right? Who's in charge of our health? We know that we can think about decisions that we make individually, right? There's always, well, get the vaccine. It's in your hands to get the vaccine. But we also know that there's those systems, those policies, and the environment in which we live, work, and play that play an important role in public health. And when I think about systems, I want to encourage Secretary Crouch because, Director Smith was very clear. Every single county department, health department is different. And I'm the head of extension here for the university, and we are in all 55 counties. And we want to partner with you because we do get funding from CDC for vaccination education. We're getting more money for adult vaccination education and many other things that we can do to try to work within the system to make it better. But when you think about the height of the pandemic in your leadership role, what was your lowest point? If you can, think back and think, well, when is it that you were like, oh my God, I'm close to just giving up, maybe, because I cannot change the number of people that don't want to get vaccinated, whatever reason that might be. But if you could sincerely answer that question, that would be great.
I'm going to ask Dr. Smith to start with his answer, and then we're just going to come right down the table. And if you could just, quickly share what your thoughts are on that. That's a great question. Thank you.
It is a great question, and I'm not sure that I'll be able to answer it to the degree that you'd like. I think that we all come to our actions in COVID and public health because of what got us here. So I'm sum total of all the parts, right? I came from a career in emergency medicine, and that taught me to make critical decisions based on incomplete information. And that also prepared me, little did I know at the time, that that incurs some resilience. And I think I'm trying to be honest with you that I was more concerned, and you've heard that come from several people here on the panel, that we need to look to those who work with us and make sure they're okay. And when we were working 7 days a week and we worked, 3 months without a break type of thing, people were tired. But there was always some bright spot. Look at what we've done. Look at what we're going to do. And look, the supplies are now better and we're getting this and we've got these people to help us. And so we always tried to look at that, not just the bright spot, but the opportunities that came forward. We were always in a position of growth. We had previously been a sleepy little health department. And this was a grand opportunity to document and demonstrate our value to the community. And I know that there's others that didn't have as robust for not any number of reasons, but we took it upon ourselves to always try to move forward and respond. So I don't know that I personally had the lowest point. We were certainly challenged. I'm not going to say that I didn't feel it, but I'm sort of hardwired to try and be a hard charger on those things. And if you present me a problem, I'm either going to go around, through, or over it. So sure.
Secretary Crouch.
Yeah, so there's a lot of ways to answer that.
You only get to pick one.
But probably 3 words that nobody here wants to hear, which is this COVID school map. I say that because it added, and that's not a good answer to your question. It added a level of workload that was just amazing, and a responsibility where the school board says that's your responsibility, not ours. I love Clayton Birch, but he pushed that right back to us. And Jeff Coben, by the way, got us through that analytical statistical model that looked at every county in terms of which schools should be open or closed. I wanted to use a dartboard, but Jeff talked me out of that. But the low point really was that period for me where we had a couple of thousand deaths, and we had the vaccine out, but we weren't really seeing a lot of change in those deaths. It was a little depressing, not a little depressing, it was a lot depressing, which I don't think anyone up here would have shown that. I certainly didn't show that to staff, because you want to keep everybody focused and trying to do the right thing. So, but there was a period there where we weren't seeing the impact that I thought we would see. I'm pretty much an optimist. I thought when the vaccine comes out, everybody's going to take this, and Clay and Jeff will remember this. I was, we're going to be back to normal here soon. We're going to, you know, this is going to, we're going to get everybody to take the vaccine, and this pandemic will be over. It took me a while. Again, Clay, Jeff, they worked real hard to educate me. But it took me a while to realize this is going to go a while. This is not over anytime soon. And it was the low point for me, seeing death after death. And if you watch the governor read those, the counties, I mean, and you sit there and you watch that at the time doing press briefings 5 days a week and going over the number of deaths. It was hard. That was a difficult time. So
Thank you. Dr. Marsh?
Well, like Lee in some ways and Jeff, my training and my background in medicine is I'm a ICU physician. So that framework helped a lot. And I think what you recognize when you're in the ICU with people that have life-threatening illnesses or injuries is, you know, we don't control who lives and who dies. We try to help as much as we can, and we support, and we trust that if people are meant to be better, their bodies will heal themselves. And if they don't, they won't. So you get pretty comfortable reasonably quickly in an ICU setting with understanding that the real decisions about life and death are way beyond our ability to intervene or to control. And I think that really was very helpful for me personally during COVID, because for me, I know that we can't rescue anybody. We can help anyone who wants to be helped. I know that we very much, all of us, wanted desperately to save every life in West Virginia and help everybody thrive. But we also knew that this pandemic and this virus, you know, were and are a once in a lifetime, hopefully infectious disease event that is not something that we are in control of. And that's the reason why that adaptive sort of leadership response, I think, has been so valuable, because we tried a lot of different interventions and some worked and some didn't, but we quickly pivoted the ones that didn't, and we learned a lot. And while our whole team and me too got tired intermittently, I think when you saw the work of so many committed people from so many different areas doing the good work for the right reasons to help people, to come together to meet a higher purpose, that this whole experience to me has been very privileged. But I come away inspired and extremely optimistic about our future. And I think we've learned a lot, but our better days as a state, as a country, and as a world, I believe, are in front of us.
Dr. Kidd?
So you'll probably recall that when the recommendations came out on vaccination from ACIP as to how the process was going to be recommended to work through different groups, it was stressed fairly high up in the hierarchy that workers were going to be prioritized, and particularly critical infrastructure workers. And so that thrilled me to no end, obviously with my background and being from NIOSH. But when the vaccine really started to be available and we had the opportunity to do that, many of the jurisdictions were not interested in having large scale worker immunization projects put into place. And that was unfortunate for many of our critical infrastructure workers. I understand certainly why, whether it was ease of administration or having different priority groups, why it was done the way certain jurisdictions did. But in some cases, we had meat packing facilities as well as grocery retailers lining up to have, people come in and do on-site workplace vaccination programs, and, just begging to have those clinics set up for them so they could get their workers immunized pretty quickly. And it never happened. And we even stood up a special arm of the vaccine task force at CDC to help them do just that. And we just could never get the interest started there. Now, many of those workers ended up getting vaccinated in other places due to their age or whatever the circumstances were. But I think it was a real missed opportunity to do a large group of workers at once, and also to prioritize them in the way they needed to be prioritized.
Dr. Coben?
Yeah, thank you, Jorge, for the question. I don't know that I would call this my lowest point, but I would say that it was certainly a time when I had a lot of frustration, and that was when I was asked to speak with the faculty senate and faculty about university policies around mandates and mask mandates and vaccine mandates. And again, as I mentioned earlier, being the voice of public health, I certainly advocated for those within the university leadership discussions that we were having, but also recognized that that leadership team was trying to balance a lot from different constituents that had weighed in on the issue, students, parents, legislators, others throughout the state that had weighed in. So trying to navigate that was difficult because I certainly respected and in many cases agreed with the faculty, yet wanted to maintain my seat at the table to be able to continue to advocate for public health as we moved forward.
Thank you. And I want to note that we're coming up against the end of our time, and we may have other people who have a question in mind, and we'll try to address those if we can, if any of our panelists have a couple of minutes to stay afterwards. But I want to thank each of you for sharing your time, Dr. Marsh, Dr. Lee, Secretary Crouch, Dr. Kitt, Dr. Coben. I think the insights today really do underscore the value of the School of Public Health here at West Virginia University and the ongoing need for the work that's happening here. And Dr. Coben, I'd like to invite you up for some closing remarks to help end our conversation today.
Well, thank you. Thank you, April. And I really couldn't think of a better way to close out this week-long celebration than this event with our panelists and April. So please join me in giving them all a round of applause. Thank you, April. I also want to send out a special thanks and appreciation to our students in the WVU School of Public Health Dean's Ambassadors, who've really helped with our anniversary events throughout the week, including today. And there is a table just outside the foyer, in the Fukushima foyer, just a few steps away. Also recognize our many partners, including the Monongalia County Health Department and the National Institute for Occupational Safety and Health, who also have some exhibits. Please visit with them. We're going to have a great opportunity to move from one celebration to the next, which is that a little bit later this afternoon, we'll be celebrating the dedication of the William A. Neal Museum for the Health Sciences Center, just out in the Pylons foyer area. It'll be a wonderful event at not only honoring the legacy of Dr. Neal, but also the history of the Health Sciences Center, which now includes 10 years of a School of Public Health. And I'm very much looking forward to the next 10 years and hope to be here to celebrate with you as we reach our 20th year anniversary. So thank you all to one and all for coming. It's a great day to be a mountaineer. So let's go. Thank you.